Hi, everyone. My name is Sophia Silao, Program Officer at the NYHealth Foundation. Before we begin, I invite you to drop your name and organization in the chat. We are recording this session and closed captioning is provided for those who need it. The topic for our webinar today is reproductive healthcare access in primary care settings. Reproductive health care has been front and center in the news recently, especially with the repeal of Roe v. Wade. Today's conversation will focus on the accessibility of reproductive health care in primary care settings, including medication abortion in New York State. And we will highlight a NYHealth Foundation grantee that works to expand access points and services. New York State has long protected comprehensive health care for women and families, including sexual and reproductive health. Abortion care is legal and has been in the state since 1970. 3 years before Roe v. Wade, the Roe v. Wade decision. And since then, New York passed several laws to enshrine reproductive rights. Most recently, New Yorkers voted to pass the Equal Rights Amendment, known as Proposition 1, at a margin of 62% to 38%, which expands protection against discrimination based on a number of characteristics, such as pregnancy outcomes, as well as race, gender identity, and sexual orientation. But access to reproductive health care, including medication abortion, is still a challenge for a significant portion of the state. A variety of educational, structural, and organizational barriers deter the widespread provision of medication abortion in primary care. And I am joined today by Silpa Srinivasulu, Director of Programs and Evaluation at the Reproductive Health Access Project, who can speak more about these barriers and opportunities to improve access to reproductive health care. Silpa oversees programs to train, support, and mobilize primary care clinicians to ensure equitable access to sexual and reproductive health care. And she's also an adjunct professor at the Heilbronn Department of Population and Family Health at Columbia University's Mailman School of Public Health. This webinar will consist of a brief discussion and Q&A at the end, and I invite the audience to drop comments and your questions in the chat, and I will try my best to incorporate as much as those as possible into our discussion. And just as a reminder, as a private foundation, we do not take positions on specific legislation. And I want to welcome Silpa.
Thank you.
Welcome, Silpa. So why don't we start by first, if you don't mind, telling us about Reproductive Health Access Project, or we fondly call it RAP, and the work that you're doing in New York.
Absolutely. Thank you so much, Sophia. First, I'd like to say that we can't talk about our work to protect abortion care without acknowledging the impacts of the election. We know that our political context will be changing, but I strongly believe that talking about who RAP is, what we've done, what we've learned, and how we can move this work forward is critical to figuring out these next steps together. So the Reproductive Health Access Project trains, supports, and mobilizes primary care clinicians to ensure equitable access to sexual and reproductive health care. We were born out of a federally qualified health center in New York City by 2 family physicians and an administrator who had some experiences where their patients would ask about abortion, but they couldn't provide abortion at their FQHC. But why? Why not within the same health system and by the same provider that their patients access the rest of their healthcare? So they figured out the operational, financial, logistical, and clinical processes to start providing abortion care in their practice. Recognizing the unique and powerful knowledge they gained through this process, they set out to share this knowledge and to support other primary care clinicians and organizations to provide abortion and comprehensive sexual and reproductive health care. So fast forward to present day, and RAP has grown into a national organization dedicated to making sure people can access comprehensive reproductive health care where they receive the rest of their essential health services. So to do this, we focus on primary care clinicians and community-based health centers, like federally qualified health centers, as well as other practices who aim to care for patients with the greatest barriers to care. So at the core of our work is our network of over 8,000 primary care clinicians who we mobilize to build power and expand sexual and reproductive health care advocacy and provision through leadership development, clinical training, and peer support. We do this because Due to abortion stigma, clinicians tend to live, work, and practice abortion, or desire to practice abortion, in isolation to avoid judgment, protect privacy, and mitigate harm. This isolation can disconnect clinicians from their communities and from others who share similar experiences and beliefs. And this isolation keeps them from advocating for change and improving access to care for their patients. So our network finds and connects these clinicians with peers who have shared experiences and goals. So our network's organizing work centers on facilitating opportunities to connect and learn in protected spaces, essentially through local networks, which we call clusters. These are state-based and professional groups that meet several times a year and are led by clinicians from their respective communities. Naturally, the New York cluster was one of the first that we started. And clusters support clinicians with leadership development, advocacy and clinical training, and to organize within their professional medical associations to ensure that teaching and advocating for reproductive health care are organizational priorities. And clusters partner with local and state reproductive health, rights, and justice organizations to collaboratively advocate for protecting and expanding access to care. This collective action and engagement helps clinicians grow into leaders who then bring others into the network and expand support for destigmatizing abortion and improving access. And this work only amplifies as the network grows, so involving more clinicians, training more, integrating new services, achieving policy and practice changes, and pulling more people out of this isolation. So while the network is the core of our organization and the community we represent, we also have various programs to support these clinicians and their health centers and patients. For example, we have an extensive resource library of patient education materials and clinical tools and resources, and we've transformed our social media communications to focus on dismantling misinformation around sexual and reproductive health care. And we coordinate a one-year clinical and advocacy fellowship for family physicians who go on to provide, teach, and advocate for reproductive health care and primary care. And lastly, what I'll spend the most of our time talking about today is our technical assistance program, which we call Project Access. While we've always helped clinicians and health centers provide abortion and early pregnancy loss care, we've recently formalized this work to support organizations across New York State and the country to expand access points for care. And through this technical assistance, we bring together multidisciplinary teams of champions within health centers to identify and problem solve the financial, operational, and administrative barriers to providing this care. And we're so grateful to the New York Health Foundation Special Projects Fund to be able to do this in New York.
Thank you, Silpa, for that background information. And you talked about how oftentimes providers can provide these services working in isolation. And I did mention earlier that there are some institutional and systemic obstacles that can impede primary care sites from providing equitable access to abortion care. Can you talk a little bit about what these barriers are?
Absolutely. Overall, structural abortion stigma is at the core of these institutional and systemic obstacles that make it harder for primary care clinics to provide abortion. Because of the longstanding controversy and violence around trying to provide and access abortion, it's been so siloed from mainstream medicine since before and after Roe v. Wade. That separation, both in policy and practice around how abortion is treated and viewed, has kept it vulnerable to ongoing attacks and has allowed persistent disparities in access and care. So one huge way that we try to work on and dismantling the stigma within RAP is the Hyde Amendment and its restrictions on federal funding. The Hyde Amendment was passed shortly after Roe v. Wade for the specific purposes of preventing low-income pregnant people from accessing abortion care. It's a rider that's attached to the spending bill every year, and it essentially says no federal funds can be expended toward abortion. The Hyde Amendment has created such deep and lasting harm in its prohibition of federal funds going toward abortion that there is this myth perpetuated that if you receive federal funds, you cannot provide nor even talk about abortion. But this isn't true. The Hyde Amendment is a restriction on your funds, not your institution. It doesn't restrict organizations like FQHCs or Title X clinics from providing abortion if they use other sources of funding to sustain it as truly separate from the federal project. So the Hyde Amendment is a huge example of these structural barriers that clinics face, because for those clinics that are willing to pursue providing abortion, it means figuring out this financial separation. So making sure you have those unrestricted funds to sustain the direct and indirect costs of providing abortion, but it also means figuring out the logistics and operations of integrating any new clinic service into primary care practice. And for clinics and staff members who have heard this misinformation and are hesitant to provide abortion care, it also means that there's this myth busting that needs to be done to persuade staff that it's not illegal to provide abortion here and that there is a way to do it within compliance. But all of that on top of your daily job of providing healthcare is a lot to manage. So it's reasonable why folks are hesitant. But I think importantly, the Hyde Amendment has not only allowed misinformation around abortion, it's allowed misinformation on early pregnancy loss care and even abortion referrals and pregnancy options counseling, which are all services that are completely allowable. There's no ban on talking about abortion or providing miscarriage management. And then another institutional barrier to providing medication abortion in primary care that really stems from this othering of abortion from the rest of medicine is the FDA REMS restrictions on mifepristone. So for a long time, the FDA has strictly regulated mifepristone under a risk evaluation and mitigation strategy, though decades of data on its safe and effective use and expert review really demonstrate that it shouldn't be regulated like this. Before 2021, mifepristone had to be dispensed in person, in clinic by a certified provider, and was not accessible in a pharmacy, like other medicines that are typically prescribed by primary care clinicians. In 2021, changes based on evidence were made to remove this in-person dispensing requirement and allow pharmacists to dispense mifepristone. And then this was formally established in 2023. But the legacy of the REMS has really made it seem to many that medication for abortion needs to be treated differently from other medication that you typically use or typically stock and dispense, or that you prescribe. So while there's a systems and clinic flow challenge to figure out in terms of what your workflow looks like with stocking and dispensing or prescribing, there isn't really anything different than what you would do in stocking and dispensing and recording things like vaccines or other medications in primary care, except that you do add an FDA patient agreement form. We've learned that this structural stigma is deeper in more rural and conservative communities than it is in cities. So like upstate New York in comparison to the city. Part of this comes from, I think, two places, like a clinic's fear about what their patient population will think about them providing abortion, especially when they know that community closely and they've seen or experienced discomfort or negative discussion around abortion. And the other part is that in these community clinics, your staff often come from a community of patients that you serve. So perhaps staff are more hesitant and uncomfortable with providing abortion because of what those conversations and values about abortion already look like in that area. Overall, I think these examples show that the history and legacy of anti-abortion policy and how it affects what people think about abortion. Also, ultimately, this work to change systems to provide abortion in primary care can't also happen without debunking misinformation and having open conversations about what providing this care really means for your patient population.
Thank you, Silpa. And it's always helpful for us to understand the parameters around regulations. And clearly there's a lot of confusion still about it. And so I kind of wanted to bring us back down to some more of the specifics of what you guys are doing with this project and really kind of hear about how the support of the NYHealth Foundation's grant has allowed RAP to address. How are you sort of using this opportunity to address some of these challenges?
Yeah, so we wanted to be able to support these health centers overcome these implementation obstacles, these really systemic barriers. So we received a grant, and this allowed us to start the New York Abortion and Early Pregnancy Loss Working Group. Our overarching goal was to create a new medication abortion access points in primary care, including federally qualified health centers. So to do this, we launched the work group with the aim of supporting at least 8 primary care organizations to provide medication abortion, or at least kind of work on those system steps to be able to start providing medication abortion. And we also use the work group not only to support these sites identify and problem solve barriers, but also for us to learn from them. So what are the structural barriers outside of their institution that we need to know about in New York so we can help them address it on a larger city or statewide scale? So we started with recruitment, and we really tried to engage more organizations outside of New York City. We had some contacts through the New York cluster and our partners at the Primary Care Development Corporation, but ultimately only one upstate site was interested in participating, but they quickly had some staffing challenges and couldn't commit to participating. So we ended up having sites only from New York City, but they were quite diverse in practice setting and community. So one early lesson learned in this process is that we really need to expand our network and build stronger relationships with organizations outside of the city. But our curriculum in this working group entailed a series of sessions focused on the key structural and institutional barriers to providing abortion. So things like building buy-in, training your staff, billing, financial compliance with federal funding, security, ordering and stocking medications, and sustainability. So each session involved a deep dive into these topics, as well as discussions around what sites were doing, what their challenges were, and problem solving together like a true community of practice. Now, 3 of our New York sites are providing medication abortion, 2 are finalizing these last steps and details before they start providing, and 1 really took the time to learn how to do this and build buy-in among leadership, and now they're ready to move forward with actually working through those details, though to be realistic, the election may slow them down due to federal funding concerns.
That's really awesome, Silpa. It's always helpful for a funder to hear how the how the resources are really making an impact to the work on the ground. And I was curious about like what the project had surfaced. What are some of the surprises that you may have discovered or uncovered in the course of the work that you are doing with the participating sites?
Yeah, absolutely. I think our lessons learned overall, some of them are surprises, and some of them just really solidified like, oh, this is a problem and it's a little deeper than we expected. And I think we can divide those lessons learned into 2 large buckets. So one being like the cultural or interpersonal, and the other being the structural. So to start with the interpersonal, one of the biggest lessons learned really is that stigma that comes along with abortion and the challenges that come along with changing institutional culture are truly more difficult than the clinical aspects of providing medication abortion. And I think that's why building buy-in is such a foundational step for implementing and sustaining this care. So while it can feel frustrating and hard, having conversations about what it means to provide abortion, hearing people's concerns and fears, and addressing them, it's time consuming, but it's time well spent. Overall, we found that our champions are more likely to find success if they take the time to understand others' perspectives and address misinformation, and really by creating a non-judgmental space for those questions. There are so many myths about abortion, and misinformation is only spreading, so we can't expect that everyone has an accurate understanding of it. And then thinking about the structural, first, the realities of primary care. Primary care settings do so much. And there's a lot of burnout and turnover in clinics that can really slow implementation on the clinical side as well as the administrative side. So for example, we had a site that basically had an internal mandate to provide medication abortion. They had a committed team of champions, like ready to make it reality. And they worked on all the systems and the operational activities, completed a range of training. But then they had some turnover with their security staff, with their legal staff, and that slowed down their ability to finish those final pieces to start providing. Another structural barrier really is funding. We learned that there needs to be a bucket of funding, especially upfront, to enable primary care settings to start up medication abortion. For FQHCs in particular, this upfront funding allows them to show and budget any abortion expenses will not touch federal funds. For all sites, those upfront costs are really around staff training and time to work on implementation. So like figuring out those clinic flows, billing procedures, EHR templates, also ensuring that your malpractice coverage does cover abortion, ordering the medications to stock in clinic if you're going to dispense in clinic. And then there is malpractice as a pretty big barrier we saw. We've known that ensuring abortion coverage in liability and malpractice policies for primary care providers is a change that health centers need to look into or make, but we found some unexpected barriers in how malpractice carriers were treating primary care providers. So for example, one of the clinics we worked with tried to add medication abortion to their coverage, but then their liability company tried to move them to like the highest risk liability category as though they were doing major GYN surgery, which was not true. We connected this clinic to resources in the state, including the New York AG's office, which is really working on reducing barriers to malpractice coverage for abortion providers. While we aren't brokers and we're not trained to read or advise on policies, we learned a few things on data and terminology that are important for negotiating with your brokers when it comes to adding abortion coverage. And then lastly, Medicaid billing. This work group really allowed us to dig into the intricacies of billing state Medicaid for abortion. There's been a lot of concern among FQHCs that they cannot actually bill for providing abortion because they have a federal benefit of an enhanced reimbursement rate. For example, California actually did not have a fee-for-service mechanism that FQHCs could use, but they created one in 2022. New York City and state does have an appropriate billing pathway for abortion that FQHCs can use. So yes, you can bill for abortion and be in compliance. So we've used the work group to share this information, and we're hoping to publish a guide on our website to show FQHCs in New York City or New York and other states what their billing mechanisms look like and what states may need to do operationally in order to ensure that their FQHCs can also tap into that state Medicaid abortion coverage policy.
So, Silpa, one of the things that always comes up in conversations is that there's a tremendous shortage of primary care providers, all over the country, and that there are potential implications to the shortage especially in communities that are medically underserved. It's the implications of that and how it plays out to the work of the work that you all are doing. I was curious to hear your take on what can be done to ensure that we can continue to expand reproductive health care, given the reality of these provider shortages.
Yeah, there definitely is a shortage of primary care providers trained to provide first trimester abortion, both medication and procedural, but there is not a shortage of interest. There's actually a bill in New York to establish a reproductive health services training program to help develop the abortion and comprehensive reproductive health care workforce in New York. So I think overall, the work that New York is trying to do is really critical to shoring up the ability of all kinds of community-based health systems to offer comprehensive care to their patients without only having to rely on standalone abortion providers, which can be really hard to access for some people. Because the people who can benefit from these training opportunities aren't just the ones who are going to work in Planned Parenthood, for example, but they're going to integrate medication abortion and first trimester procedural abortion in different practice settings and communities where they go on to work. And given the limited access to abortion care currently in more upstate and rural areas of New York, this can be a really critical opportunity to expand access and begin destigmatizing abortion to help communities really view it as part of routine healthcare that belongs in primary care. And what I'd like to see next after that piece is also being able to train and build the workforce and capacity of systems and whole healthcare teams to provide abortion as part of routine healthcare. So not just the healthcare provider, but the front desk staff, nurses, medical assistants, everyone who makes the whole system and patient care experience possible.
Awesome. The Silpa is a very creative solution to this problem. With October's election behind us, what is RAP keeping an eye out on in the coming months?
Yeah, there are several things we're keeping an eye on post-election that really impact New York State and the country as a whole. There are going to be some links in the chat, but they have very fear-mongering titles, but they really are a good overview of the risks we should pay attention to. So I just wanted to give that warning up front. But the first two things I'm keeping an eye on really speak to primary care at large. I think we all know the risk of appointing RFK to lead HHS, and that will have deep consequences on access to affordability of preventive health care. And then there's the risk that there will be primary care defunding, especially with reducing funding for Medicaid. Trump has supported policies to repeal or weaken the Affordable Care Act and to cap and reduce Medicaid financing. So with the support of Congress, this could happen this time. So that's something systemic that really will affect the full primary care workforce and patients. And then thinking about reproductive health care in particular, there is the risk of attempting to block abortion access nationwide through various means. So the Trump administration can decide to use what ACLU and Guttmacher call a legally unsound interpretation of the Comstock Act and enforce it. So they would try to use the Comstock Act to make it a crime to send or receive drugs or articles used in abortion care by mail. This would effectively amount to a nationwide abortion ban because the medication and equipment for abortion procedures need to go from supplier to clinic, clinic to patient. But there are a few important things to keep in mind. First is that the DOJ, courts, Congress, everyone has made it clear that Comstock does not apply to legal abortion care, and birth control is not included. It's also possible that states can refuse to participate in improper federal enforcement efforts, so that may potentially give states like New York the power to reject this kind of unjust overreach. And then Congress may try to pass an actual national abortion ban or gestational age restriction, but this is unlikely to happen through legislative means because of the filibuster. However, Congress may try to eliminate the filibuster rules and get this kind of agenda passed. But it's also important to note that a federal law like this would likely supersede state laws. So this could be a situation that's very challenging for New York to try to protect access. But then we have to think about the FDA. So the FDA's approval and rules of governing mifepristone on medication abortion. It is possible that a Trump appointee within the FDA will severely restrict or eliminate access to mifepristone. They may push to reinstate medically unnecessary requirements like having to get the pills in person. They may take an extreme route of rescinding the approval altogether, which would be unprecedented for the FDA, and of course, just ignore 25 years of evidence and safe, effective use of mifepristone. But I have a hard time believing that the power of big pharma would allow something like this to happen, because it would set a precedent for other drugs and really continuing to foster a lack of trust in our medication approval process. And it's important to note that no matter how the FDA treats the pills used for medication abortion, they aren't going to disappear. These drugs will exist and be made, and people will continue to find ways to get them and manage their abortions on their own terms outside of the traditional medical system if needed. But the more that access to this care is driven outside the formal medical system, the more at risk people are for being criminalized for their health care. And again, the more stigmatized abortion becomes. It's also likely that Trump will reinstate rules on Title X to prohibit providing and referring for abortion services. The administration might also try to fund and embolden crisis pregnancy centers that coerce and manipulate people into keeping pregnancies that they may not want. And no one is necessarily talking about the Hyde Amendment and FQHCs, but we know that a Trump administration would likely do something similar to the domestic gag rule on 330 funding, or just their existence as an anti-abortion administration will have a chilling effect on clinics who want to provide abortion care. So like the risk of following these compliance rules to provide abortion may feel too great under a Trump presidency compared to Biden or Harris. And what I worry about and what RAP is currently focused on preventing is the potential of this chilling effect on trying to provide miscarriage care and other pregnancy care, even though, again, it's completely within FQHC scope of services. So even if the rules around federal funding of abortion stay the same, there is still this fear that you may draw attention to yourself, and that's real. But we've also talked to the clinics that we're working with who are trying to provide abortion care, trying to provide miscarriage care to their patients, and they are still committed and driven to really ensure access to this care for their patients, though they are reasonably cautious and paying attention to these same issues.
So I see a number of questions coming in the chat, and I do want to invite others in the audience to go ahead and send your questions in. First, one question that came in was, let's see. The first question was connected to promoting and conducting outreach and education to community members about abortion by community outreach staff paid by federal funding. Can you talk a little bit about this? And I think it was tied to, some of the parameters around regulations and such.
Yeah, I can't provide legal advice, but I can provide the information. I'm also not a lawyer to even provide legal advice, but can provide kind of the information and the sense of understanding from our experiences. But of course, each site is going to be a little different. If you are not providing abortion services, and I'm assuming that this is just an FQHC perhaps, let's take Title X funding out of it. This is not providing abortion. This is providing information. And so kind of by the letter of what we understand, talking about abortion, providing education about abortion is not the same as providing abortion services, which is what the Hyde Amendment restricts. And so if you are providing abortion services and you have a team of health educators and outreach workers who are talking about abortion that may be connected to the services that you provide, that's when you want to ensure further that there is that financial separation. But again, this is just kind of an assumption based off of what I'm making of this particular question and context, because the Hyde Amendment talks about provision of abortion, and this example sounds like talking about and educating on what abortion is.
One question that came in was related to the project. And question about, for primary care sites that couldn't quite get over the hump of providing this level of care at their own clinics. What are some of the technical assistance or support that RAP can provide those particular locations?
Yeah, what I love about our team is that we're really flexible and committed to getting sites what they need to start providing. So we might just start with a conversation with you to get a sense of your history and site context. We'll definitely help you come up with a plan to identify and address the challenges that you're experiencing, whether it's administrative, logistical, clinical. And then in terms of some more specifics, we may help you build a team at your site to work on this implementation. We'll give you recommendations of best practices like clinic flow ideas. How do you actually stock and dispense mifepristone? How do you order from the distributor? If you receive federal funding, we'll talk about and help you plan out financial separation. We'll make billing recommendations. We have a few guides that can kind of serve as a template. We'll help you develop clinic policies, and then we can connect you to resources for safety and security or legal compliance. We can train you or facilitate ourselves, values clarification workshops, medication abortion counseling training, support staff training, or clinical training itself. And same with medication management of early pregnancy loss. We can also help you create resources like patient education materials, consent forms, protocols, EHR templates. And importantly, we'll bring you together with a community of clinicians and staff who are doing similar work. And sometimes that community and handholding can be what you need to move forward.
So one question came in that sort of touches on some of the complexity to implementation at sites is, reporting requirements to the DOH e-vital system. Can you speak a little bit about that?
I don't remember all the details of the changes that were made or the requirements that were made, but I know this came up for a few other sites, especially because primary care sites tend to see so few abortions. So that kind of reporting process and implementation, I think, can be a challenge when you're only doing so few. I'd be happy to talk after and see if we can provide more support around that.
And, Silpa, I know that there are other things in the works for you and RAP, right? I'm curious to hear more about what's in the horizon.
Yeah, absolutely. I think there's quite a lot on the horizon, and I think as what we're really thinking about first is how do we respond to the needs of clinicians and the communities that we work with? Because it's hard to anticipate what policy changes will happen first, but we are really committed to protecting and strengthening access to care. Um, and I find it hard sometimes to describe precisely how we'll respond to these threats because I've always seen RAP as the solution to these kinds of threats in a way. Like we bring together clinicians to figure out solutions to access in their communities. We combat misinformation through our clinical tools and patient education resources. We integrate reproductive health care, especially miscarriage management and abortion care. in the settings where people access the rest of their healthcare. And these are all ways of expanding access under threats.
Mhm.
But in New York in particular, we're really excited to be part of a team with the CUNY School of Public Health, Advocates for Youth, National Institute of Reproductive Health, who are all hoping to work with CUNY and SUNY campuses to support them integrate medication abortion and patient-centered referrals to increase access for their student populations, as mandated by a 2023 law. So we're hoping to combine our collective expertise and resources to really ensure that students across the state have access to care that they may need. And we're also hoping to continue this work across the state and with other primary care providers who want to offer the service to their patients.
So we have quite a range of folks who are joining us today, some who are representing the philanthropic community. And I wanted to pose this question to you, Silpa. Talk about what funders can do to help, or what you'd like to see, funding partners to be able to help advance this work.
Yeah, thank you. I think there are really two key ways that philanthropy can unite around protecting abortion in New York right now. And first is to support organizations like RAP that are working on creating new access points for care in the communities and spaces where patients already access the majority of their healthcare. This work isn't costly because it can truly be sustainable when we think about the amazing infrastructure that New York has around health insurance. So Medicaid coverage for abortion, a really critical public safety net, and a mandate that private insurance also cover abortion as well. What's challenging is this upfront cost of setting up the systems to provide abortion. So the clinical and counseling training for all staff that may need to be involved, ensuring your malpractice covers abortion, the staff time it takes to set those systems up. And when we think about clinics that have federal funding, we have to remember that they need to have some of that money upfront to prove that no federal funds will go toward providing abortion. So we need to give everyone the tools and resources they need to set things up, but we can't do it for them because we're not at the health centers themselves. So supporting both organizations like ours and clinics themselves that need that upfront support can really enable that sustainability for the future. And then another key way that philanthropy can be supportive at this time is always support abortion funds like the New York Abortion Access Fund. They support New Yorkers and people traveling to New York State to access care. And the people that they support are the ones who are struggling the most to obtain timely abortion care and whose costs are more expensive because of the delays they've experienced and needing to travel so far to get care here. With the election, no doubt we're going to see more travel into New York. So we need to have the resources to support these patients. And we need to create more access points for care so everyone can get timely abortion care.
And what about for others who are not from the philanthropic community? What are some of the ways that they can get involved with the work of RAP?
Yeah. If you work in a healthcare setting, I feel like whether or not you're ready to provide abortion, I think it's critical to just talk about reproductive healthcare access wherever we work and live. Abortion in particular has always been talked about in a hush-hush way, and that just contributes to the stigma and fear surrounding it and why people still view it as not basic healthcare. So we all have a role to play to be part of this myth-busting movement. I think I really encourage everyone to use social media, LinkedIn, other platforms to just demystify information about abortion and other reproductive health care. So just sharing content that other organizations like RAP, the ACLU, Planned Parenthood, and other trusted sources, sharing that information. I also hope something that you all take away today is that it's not illegal to provide abortion if you receive federal funds. The Hyde Amendment is a restriction on your funds, not your institution. So while it is challenging to financially and operationally separate abortion from federally funded services, it's possible and it's not illegal. So really dismantling this misinformation around the Hyde Amendment can slowly help reduce stigma around abortion in primary care. Of course, the federal rules may change, but it's something we're keeping an eye on.
Thank you so much, Silpa. And this was extremely informative, and thank you for sharing your knowledge about all of these various topics. I want to thank you for your time, and I also want to thank the members of our communications team, Erica von Boxtel, Maureen Corzine, and all of their help for and their steady hand behind the scenes. Before we wrap things up, I would like to make a quick plug for NYHealth's Advancing Maternal Health Equity RFP. It's a little bit of a shift, but it is sort of tied to ensuring that we expand access to reproductive health care. This funding opportunity will support projects that identify racial disparities in maternal health care and outcomes, use primary and preventative care to reduce those disparities, and measure progress to improve racial health equity. We do have a application deadline coming up. The deadline is January 10th, 2025. And we will drop a link to this funding opportunity in the chat as well. And thank you very much for dropping that in the chat. I do see that there's one last question before we sign off, and I wanted to give it the time. A question about recommendations on how to best provide safe and protected path for immigrants that live in other states who need and seek abortion services in New York. Do you have any thoughts about that?
I don't have any specific recommendations I could offer. This isn't my area of expertise, but I think the New York Abortion Access Fund would have a lot of ideas about how to support this particular community. And I think New York has really done a lot of work around being a sanctuary for people who need healthcare and services and who may not have documentation status. And I think that's also the role of FQHCs and primary care, to be able to care for patients regardless of documentation. I'm sorry, I can't provide more ideas.
No, this is very helpful. Again, a lot of resources that we've been dropping on the chat. And so in addition to the RFP that I mentioned, a copy of this webinar is also going to be available on our website. And so I invite everyone to take a look at that, and obviously take a look at RAP's website, and feel free to reach out to Silpa if you have any other questions. And with that, I'm going to close out and wish everyone a happy Thanksgiving, peaceful and happy holiday season. And thank you, Silpa, once again. And thank you, everyone, for joining us for today's webinar.